Hello viewers, welcome to my channel. I am Dr. Puspen Dasgupta. If you're new to this channel, I am an ENT specialist from India and naturally I upload videos related to ENT. I've got a great response from viewers on YouTube and I have decided to upload one video on each day of the week and it will follow a particular theme. Monday videos will be about MS ENT, Tuesday MBBS ENT, Wednesday MRCS ENT OSCE, Thursday MRCS Part A, Friday English Language Proficiency Test so that one can emigrate to an English language speaking country like the United Kingdom. Saturday will be cool because it will talk only about travel videos documenting my travel experiences in the United Kingdom. And Sunday we'll talk about the differences between the scenario in India and UK, especially from the point of view of a doctor. Sunday will largely be a serious conversation regarding the challenges that one encounters while making the transition from India to the UK. So if you are one of the few viewers who are watching from outside India, I hope this video still helps you because the transition to UK is difficult for everyone, irrespective of which country you are transitioning from. So with that out of the way, I also want to mention that I go so far as to call this a channel. So the episodes on this channel should be released at a definite time on a definite day. So I'm happy to announce that all of my videos will be released at 9 p.m. India time every day. I will try to honor the time and the theme and the regularity of uploads going forwards, and I'll also try to keep the content engaging. So Monday being MS ENT, today we are going to talk about a very interesting question, auditory brainstem implant. I know the people who are interested in travel videos or MRCS or MBBS ENT assessment will immediately tune out. But please don't do that. The world of ENT is interconnected. A question that is today asked in MS ENT can tomorrow be asked in MRCS ENT and definitely can be a possibility during your MBBS assessment. So I've stated this before and I want to state this again. The syllabus for ENT always remains the same. It is just that the expectations from the examinees keep changing depending upon the exam. So I hope you like this video about auditory brainstem implant, and I'll be happy to receive the feedback that you have in store for me. Take care, stay tuned, and let's enjoy this conversation about auditory brainstem implant. The theory exam in MS ENT is actually quite challenging. Why is it challenging? Because it usually involves 4 papers. Each paper has 10 questions. Each question is of 10 marks, and you have to write answers to 10 questions in 3 hours. So if you want to do justice to all 10 questions, then you should not devote more than 15 minutes to each answer. Now, it is very difficult to write a 10-mark answer in 15 minutes. It has to be comprehensive enough to fetch as many marks as possible, and it also has to be concise enough so that you can finish writing it in 15 minutes. So it is a challenge which requires both practice and research. Unfortunately, in many cases, we can't find answers to commonly asked questions in theory exams from one textbook. So we have to look at multiple textbooks to find an answer which is good enough in terms of the expectations that examiners have from us. So this is my attempt at creating an answer that I hope is both concise and comprehensive. And for the purpose of writing this answer, I have used a very good book called Surgery of the Ear, 6th edition by Glasgow and Shambo. In my opinion, Glasgow and Shambo is the best book for all things related to otology. I hope you will like my answer. A rule that I used to follow while writing answers during post-graduation was, if it's a 10-mark question, I would write 10 pages. This is a rule that you can ignore, but this is a rule that proved to be quite useful to me. So my answer for brainstem implant would start with describing brainstem. Brainstem consists of midbrain, pons, and medulla oblongata. I hope the answer is visible to you. After I have described brainstem, I would describe the auditory pathway, which starts at the cochlea and then goes to the cochlear nucleus on either side, Then there is decussation of the nerve impulse to the superior olivary complex of the same side, ipsilateral, and the superior olivary complex of the contralateral side. Then the impulse moves up to lateral lemniscus, inferior colliculus, medial geniculate body, and finally area 41 of the auditory cortex. Easy way to remember that medial geniculate body is in the auditory pathway and lateral geniculate body is a part of the vision pathway is M for music, M for medial, and L for light, L for lateral. Moving on, I have described the auditory brainstem implant as a device which was developed to bypass the auditory nerve and directly stimulate the cochlear nucleus complex. In 1979, William House and William Hitzelberger first implanted an electrode to stimulate the cochlear nucleus of a patient with NF2 facing deafness after excision of a vestibular schwannoma. If you're watching my video, please help me by mentioning what is Hitzelberger's sign in the comment section below. Multi-channel version of ABI successfully completed clinical trials with the United States Food and Drug Administration in July 2000 and received approval for commercial release. Now here, for the benefit of the examiner, I have described how my answer will be written. First, I will talk about patient selection, followed by device and preoperative counseling, followed by anatomic considerations, then surgery and post-operative scenario, followed by recent advances and opportunities for further research. Next, so I start talking about patient selection, and it has been observed that in at least 90% individuals with neurofibromatosis type 2, bilateral vestibular schwannoma is exhibited. Ideal goal in management of NF2 remains hearing preservation by early diagnosis and treatment. However, ABI is an alternative to preserve non-serviceable hearing when large tumors are present and hearing preservation is unlikely. What is non-serviceable hearing? This is hearing loss that cannot be improved with the use of hearing aids. Multi-channel ABI is approved for use in individuals with NF2 who are at least 12 years of age. So I don't really know what to write in pediatric brainstem implant surgery, probably a 12-year-old patient, or probably we can talk about pediatric age being increased to 18 of late. I really don't know. There is no preoperative audiological criteria as remaining hearing is eliminated by surgical procedure for tumor excision and by the placement of the electrode array. Performance with ABI has not reached cochlear implant levels, but can significantly enhance the quality of life. I'll describe this in greater detail later on in the answer. Implantation may be done during first side vestibular schwannoma removal, second side vestibular schwannoma removal, or bilateral vestibular schwannoma, or even after bilateral removal of vestibular schwannomas. So this is possible when you're removing vestibular schwannoma of the first side, when you're removing the vestibular schwannoma of the second side, or even after both sides vestibular schwannomas have been removed in previous surgery. ABI is not for everyone. The factors influencing ABI benefit are age. Paradoxically, young people are less enthusiastic about ABI use, general health, social activity, anatomical status, which can be monitored using MRI, and vision. Vision is very interesting in that in patients who use ABI, sound sensation along with lip reading is used to participate in oral communication. If the vision is limited, then the ability to read lips is lost. So patients report less benefit with ABI if they have limited vision. However, if they are completely blind, then imagine a completely blind person who also becomes completely deaf following vestibular schwannoma surgery or ABI surgery. Then with the use of ABI, they get some sound stimulus, some auditory stimuli. So they will report benefits after ABI. They are likely to report benefits after ABI. So limited vision, less benefit, completely blind, benefits are reported. Now I described the device. The first ABI device was developed by Hitzelberger. Please mention Hitzelberger's sign in the comment section below. This ABI was similar to the cochlear implant ball type electrode. It was a single electrode. Then we moved on to 2 to 3 platinum ribbon electrodes used in a 2 by 8 millimeter fabric mesh array. In 1992, 8 electrode multi-channel ABI system was developed And currently we use 21 electrode system with receiver stimulator. The general goal is to link low frequency sounds with electrodes that sound lower in pitch, and likewise with higher frequency sounds. The process is relatively straightforward in cochlear implants because of the highly consistent tonotopic arrangement of neural processes in the cochlea. However, with ABI, the process is much more complex due to individual variations in neuronal survival, cochlear nucleus anatomy, and electrode placement. Programming ABI speech processors takes more time than cochlear implant programming. Here I have drawn a fairly unimpressive picture of a 21 electrode ABI. It's a good idea to draw diagrams because not only does it create a good impression, it also occupies valuable real estate in your answer. Preoperative counseling for ABI has the goal of helping patients prepare for the hearing loss they are likely to encounter after removal of the tumor. And it's also important to teach them how to acclimatize to a new way of hearing with ABI. This has to be done before the surgery. Proper expectations regarding benefits and limitations with this device should be explored during counseling. And it should be explained to the patient that they can experience tingling, dizziness, and even absence of auditory sensations after ABI. So even after ABI, they can experience no auditory sensation. This is possible. So it is important to maintain a tone of hopeful and cautious optimism. A multidisciplinary team is used in ABI surgery. The key members of this team are the surgeon, the electrophysiology monitoring expert, and the implant audiology expert. The role of the surgeon is removal of the tumor and preservation of the necessary structures, and also accurate placement of the electrode array. The role of the electrophysiology monitoring expert is confirming that the implant site has been properly identified and the electrode array has been placed at the proper site. The implant audiology expert is responsible for programming the speech processor and optimizing performance perceptually. Next, we talk about the anatomical considerations in auditory brainstem implant. What is the target site for electrode array placement? It is the dorsal and ventral cochlear nuclei. Now, knowing this is not enough. You have to know where the dorsal and ventral cochleae are located. They lie within and on the superior aspect of lateral recess. So you have to find the lateral recess. The nuclei are hidden by the cerebellar peduncle. So how do you find the lateral recess? Some landmarks are used. In this case, there is the intact choroid plexus, which marks the entrance of the lateral recess, and there is obliquely traversing tinea, which on the roof of the lateral recess mark the surface of ventral cochlear nucleus. However, these two landmarks can be distorted by the presence of a large tumor, in which case you have to look for alternative landmarks like the 8th cranial nerve, the stump of the 8th cranial nerve, which can be traced to the opening of lateral recess, and the 9th cranial nerve can also be used as a reference point for lateral recess. However, the concavity between 8th and 9th cranial nerve is not the introitus of the lateral recess. Now let's talk about the surgery for auditory brainstem implant. The surgical approach is translabyrinthine craniotomy. The electrodes are placed to monitor, some electrodes are placed to monitor electrically evoked brainstem responses, also known as EABR, and any activity from cranial nerve 7 and 9. These electrodes confirm the proper positioning of the electrode array. Now the tumor is removed by the translabyrinthine approach. The device is placed into a pocket in the temporal area by making a post-auricular incision. Prophylactic IV antibiotics like 3 grams of cefuroxime are administered at the time of induction of anesthesia. EABR monitoring helps in confirming proper placement of ABI electrode array, as I previously mentioned. This will be done by the electrophysiologist who interprets the waveforms and provides feedback to the surgeon regarding the placement. Now, for EABR monitoring, subdermal needles are inserted at 3 locations: at the vertex of the head, at the 7th cervical vertebra, and at the hairline of the occiput. Now let's discuss the steps of the surgery. As previously mentioned, the tumor is dissected by translabyrinthine craniotomy. Tumor is completely removed, hemostasis is achieved, and then the site for internal receiver is determined posterior superior to the mastoid cavity. From this site, temporalis muscle is elevated and excised to expose an area of bony cortex. This is a circular area. This circular area of bony cortex is flattened using cutting burrs and using a replica of the receiver stimulator as a guide. So a trough is created between the implant seat and the mastoid cavity for placement of electrode wires. Then suture tunnel holes are created on either side of the receiver stimulator. What is the role of the suture tunnel holes? These tunnel holes are fixed with nylon suture before electrode array positioning so that manipulation of the leads does not alter placement of the electrodes. After implanting the internal receiver, monopolar electrocautery should be abandoned, because if you use monopolar electrocautery after placing the internal receiver, there is a possibility that current transmission can occur through the implant to the brainstem. So you can only use bipolar cautery after this. Opening of the lateral recess is located using the surgical landmarks that I've mentioned earlier, but as a final confirmatory check, location of the lateral recess can be confirmed by noting the egress or leak of cerebrospinal fluid as the anesthesiologist induces Valsalva maneuver. However, this should be done only once. So then foramen of Luschka is identified. Electrode array is mounted on a Rosen needle, and the electrode array is oriented superiorly and it is inserted into the lateral recess. And for best results, electrodes should be placed fully within the lateral recess. Then selected electrodes in the array are activated to confirm their position over the cochlear nucleus. A small piece of Teflon felt is packed into the meatus of the lateral recess to secure the electrode array, and further stabilization of the electrode array is achieved by subsequent ingrowth of fibrous tissue. Electrode wiring positioned within the mastoid cavity and the bony trough. Eustachian tube and middle ear is packed with oxidized cellulose and muscle. Mastoid defect is obliterated using abdominal fat. The magnet is removed from the receiver stimulator to allow for further surveillance with MRI, because if you have a magnet inside the body, then MRI becomes difficult. So how do you identify the location of the receiver stimulator after removing the magnet? You have to tattoo the center location of the circular receiver stimulator antenna. So the center location of the circular receiver antenna, the center location of the circular receiver stimulator antenna is tattooed to facilitate its location post-operatively. Then the incision is closed in layers without placing any drains. So if there is no drain, then there is a possibility of post-operative hematoma formation. To prevent this, a large mastoid type dressing is left in place for 3 days. If there is moisture observed on the bandage, then it is a sign of CSF leak, which should be promptly identified. The device is activated for the first time, typically 4 to 8 weeks after implantation, to allow resolution of edema in the skin flap overlying the receiver stimulator. However, implant patients usually shave this area and apply a thin tape and metal disc called retainer disc to which the magnetic transmitter coil adheres. Any complaints about poor signal or deterioration in sound quality can, in many instances, be traced to proper or improper positioning of the retainer disc. Now, the most important complication following auditory brainstem implant surgery is CSF leak. CSF leak can lead to meningitis, which is an unusual complication of auditory brainstem implant surgery. However, meningitis can also happen spontaneously. If meningitis develops, it can respond to antibiotics and controlling of the CSF leak. The CSF leak can be prevented by meticulous dural approximation. However, the dura cannot be closed in a watertight manner, so it should be approximated as close as possible with plugging the residual dural defect with strips of abdominal fat. If CSF leak has happened, then it can be controlled by first reapplying the mastoid pressure dressing and bed rest. If this fails, then lumbar subarachnoid drain can be attempted. If this also fails, then blind sac closure of ear canal is done. Blind sac closure of ear canal. Re-exploring the wound and trying to identify the defect to close the CSF leak, to plug the CSF leak by re-exploring the wound, that method is not recommended. So what is the post-operative outcome after auditory brainstem implant surgery? The speech perception with ABI typically does not match the very high levels generally attained with modern cochlear implants. What is seen after auditory brainstem implant is auditory sensations in conjunction with lip reading enables patients to participate in oral communication. Substantial improvement in performance over time is seen in ABI recipients. An improvement has been seen to be happening even after 7 years of ABI surgery. So patients should be counseled before the surgery that regular use of the device greatly enhances performance. What are the recent developments in ABI technology? ABI recipients, as previously mentioned, do not show the excellent levels of performance that can be obtained with modern cochlear implants, possibly due to the fact that they do not have auditory nerves, or because of the fact that some undetected damage may have occurred to the brainstem, either by the tumor or by the surgical removal of the tumor. There are some alternative options which are under research, where the lower brainstem can be bypassed by stimulating inferior colliculus, by either using an auditory midbrain implant or an inferior colliculus implant. However, these are still under research. Penetrating auditory brainstem implant has been developed and is under evaluation. It has been observed that penetrating auditory brainstem implant performs best when used in combination with surface microelectrodes. Each electrode type offers its own advantages. Best use seems to be when they are used synergistically. Further research is required to produce better hearing and speech outcomes following brainstem implant surgery. I hope this answer is good enough for MS ENT theory exam, and if you encounter this question in your postgraduate exam, then I hope watching this video would help you. So I hope I have created an answer which is both good enough in terms of content as well as the possibility of you finishing this answer within 15 minutes. If you have any feedback, if you've identified any mistakes, if you want me to answer any other questions, then please feel free to mention it in the comment section below. Thank you so much for watching. Take care. I hope I'll see you again in the next video very, very soon. Bye-bye. Take care.